So good afternoon. Welcome to today's symposium about optimizing the outcomes for our TAVI patients, all about the key considerations for the first valve choice and making sure that we optimize the procedural outcomes. So my name is Didier Cheche. I'm working in Toulouse, and I'm really pleased to host this symposium. And I would like to remind you that this is an educational symposium that is dedicated to you. So if you have in mind any kind of questions, comments, issues that you would like to be addressed during this symposium, please feel free to pop up your questions live, and we will try to answer it with the distinguished panel that we have now. So to help me to run the discussion today, I have the great privilege to share the discussion today with my friends. First, Ran Kornowski from Petah in Israel. Hi, Ran.
Hello. Hello, Didier.
So, yeah, good to see you. And there is also my very good friend, Lars Sondergaard from Copenhagen. Hi, Lars. And last but not least, Doug Fraser from Manchester. So, hi, Doug.
Hi, Didier. Hi.
So, okay. Guys, we have a couple of objectives today. First, try to recall data about hemodynamics and durability, trying to understand why the choice of the first valve matters at the index procedure. And second, trying to understand how we can optimize the procedural steps to get the best out of the device that we use for our TAVI patients. So I would like first to ask you, Ran, to drive us through the reasons why the choice of the first valve is very important at the index procedure. So Ran, the floor is yours. Thank you.
Thank you very much. Thank you, Didier. It's a real pleasure to participate in the meeting. And I was asked to talk about choosing the first TAVI valve and what we should look for when we plan and decide about the TAVI procedure. I'm not going to talk about surgical valves because this is not about the decision between TAVI and surgical AVR. So the TAVI goals are very clear. We have to assure short and long-term success. And these are the considerations that we have to make when choosing the right valve for the right patient. We have to take into account everything. For the short-term consideration, we have to achieve perfect procedural goals. And in order to do so, we have to consider the clinical details, the imaging details, both by echo and CT, comprehensive CT, and all the associated procedural detail. Everything should matter. Everything should play a pivotal role in order to achieve the perfect results. Now, the goal is very clear. We have to have the perfect TAVI, the optimal result without complication. And how do we achieve that? In order to achieve this goal, we have to take into account many variables and many considerations. First of all, we have to look at the multidimensional complexity of TAVR. And also, we have to remember that we have different valves. We have the four major players nowadays: Sapien, Evolut Pro, the accredited, and recently also the Portico. So how do we navigate between these four devices? And many parts of the world, there are additional devices. So TAVI valve selection should be based on multiple considerations. We start with patient characteristic. We look at the ECG. We look at the access. We look at the dimension, the eccentricity, the clinical scenario, whether it's valve in valve, whether it's a native valve, whether it is a bicuspid valve, whether we look at the patient prosthetic mismatch issue, whether it is especially a large annulus, whether there are some access height issue, etc. Every part of this puzzle counts. Every part of this puzzle can dictate whether this is going to be a success story or whether we are going to face complication. and there is no cookbook, there is no recipe, and every patient and every characteristics makes a formed decision by the team what is the best option for the patient. I think the heart-team dialogue is very, very important. We have to have a very open dialogue in the heart-team meetings, detailed patient presentation, comprehensive echo analysis, as well as cardiac CT and cardiovascular CT. We have to have a deep knowledge of the different features of the THV devices. The team experience and preference is also very important. And also, I would recommend to have a THV diversity, not to be stuck with only one valve or even two valves, in order to have a better adaptability to the different clinical and technical scenario. Recently, we have performed an interesting analysis from our Amtrak multinational and multi-center registry. We actually saw and were able to demonstrate that the valve preference and the valve dominance clearly matters. So we distinguish between centers that use mainly the core valve device versus those centers that are mainly use the Sapien device. And we saw a very interesting finding. For those that have used a self-expandable core valve or the Evolut devices, it didn't really matter whether those centers have used balloon expandable versus the self-expandable valves. The results were pretty much the same. But interestingly enough, for those centers that use predominantly balloon expandable valve, if they used the self-expandable valve, results were worse. Mortality by 2 years was higher, pacemaker rate was higher, etc. So there is something in the valve preference as well as expertise of the team that probably dictates or associated with the overall outcome of the patient. And this is something that needs to be paid attention by each team. Then we have to look about the long-term consideration. And long-term consideration are mainly a derivative of the valve durability. And there are several studies now that show what is the durability of the valve according to the most contemporary valve 3 definition. So if we look at the most recent analysis from the partner 2 study, we can find out that the bioprosthetic or the structural valve deterioration using the Sapien 3 over a period of 5 years is around 4% in intermediate risk patients. We don't have much data more than that. It has been worse for Sapien XT, and it is very similar compared to the surgical group. For the core valve high risk, we have 5 years data. And the bioprosthetic valve degeneration data are actually pretty good in order to define the auto distinguish between the moderate degeneration, which was around 9%, versus the severe degeneration, which was about 1%. So relatively low rate of degeneration over the course of 5 years among the high-risk patients. What about the NOTIONS trial? Recently, this was published in the European Heart Journal. Lars is here on the panel. And I see here that you can see that the structural valve degeneration over the course of 8 years have been, according to the definition, between 9% and 14%, whether ppm was added to the definition. And again, this was even a better rate compared to the surgical group. What about the TAVR in TAVR? Please remember that we have option for the long term to perform TAVR within previously performed TAVR procedure. And this is a very, very valid option. And according to a most recent study that will be soon published, it doesn't really matter whether we implant TAVR within a balloon expandable or self-expandable valve, What is really the only difference between the two procedures is the fact that the residual high gradients are much higher if we use the balloon expandable versus the self-expandable, but the overall results are pretty much the same. So in conclusion, I think that the first TAVR selection during TAVI take into account the patient and procedural specifics, the short and long-term effects geared towards optimize outcome at any time point between the procedure and during the follow-up. Valve dominance at specific site should reflect the team experience in using balloons versus self-expandable valve. This matter could be of clinical importance and needs further investigation. And the long-term structural valve degeneration or bioprosthetic valve failure data for TAVI are favorable up to 5 years, although there are no comparative head-to-head analysis of valve durability to help dictating the long-term THB preference. This is the data we had so far, and this is ongoing journey for all of us. Thank you very much.
So thank you very much, Ran. This was a very straightforward presentation, and we clearly understand the importance of hemodynamics and durability for the first valve choice. So 3 short questions to you guys. The first one comes to you, Ran. What about patient prosthesis mismatch? Is it relevant in your practice for your valve choice?
Patient prosthesis mismatch is very relevant and in some circumstances might dictate the valve choice. For example, if we are going to have a very small annulus, and if the sinuses are relatively large, we may elect the self-expandable Evolut Pro or Pro Plus platform. If the sinuses, with a very small annulus, if the sinuses would be relatively small, we may elect the platform. In large sinuses and or large valves, the patient prosthetic match is less of an issue. In very obese patients, definitely patient prosthetic mismatch may be an issue. In valve or TAVI in TAVI, it becomes a greater issue if we are going to implant into a small bioprosthetic. So yes, patient prosthetic mismatch is an issue. It could become a symptomatic issue. And to what degree it is a prognostic issue, we have to see about that.
Thank you very much. Maybe a short question to you, Lars, about durability. Do you believe that the baseline gradient, residual gradient after the procedure has an impact on potential structural valve deterioration during the follow-up of the patient?
Yeah, I think we have seen quite robust data, at least from the surgical valve, that if the patient got moderate or particularly severe patient prosthesis mismatch as baseline with high gradients, of course, that valve is going to fail early on, and also the patient will have a high risk of cardiac mortality. So I certainly think we need, as Ran was saying, we need to identify the patient with small aortic anomaly and also to choose a good platform which is going to provide the optimal hemodynamics outcome and thereby better durability and also better survival rate.
So thank you very much, Ran. So maybe one last question to you, Doug. So Ran said that we needed different platforms. According to your experience, how many platforms do we need? Or can we treat any kind of patient with a single device? What would you advocate?
Well, we use balloon expandable and we use self-expanding, and I'll show a case of a self-expanding. I think it's really important to be comfortable with at least 2 platforms. And my interpretation of Ran's data was that when self-expanding was just used for particularly high-risk cases in small volume, that didn't lead to the best outcome. So I think that we should be comfortable with at least 2 platforms. There's a trade-off because you need to be doing a good volume of each procedure. but certainly we were very pleased when we adopted a second platform. We're not actively looking for a third at the moment, but if the volumes can justify, then I'm sure there would be niches for a third.
So thank you very much, guys. So just to briefly wrap up that section, very important. So for the choice of the first valve, keeping the hemodynamics in mind makes sense because we need to achieve gradients as low as achievable for our given patients, particularly in small annuli. Larger EOAs, and potentially this may have an impact on durability in the future. And we need to work with at least 2 platforms, potentially more, just to be able to tailor the device to the patient to make sure that we achieve the goals for the patient. This is for the long-term follow-up of the patient, but let's bring back our spirit to the procedure itself. And it's my great pleasure to ask you, Lars, to drive us through the procedural steps to optimize the outcomes for our patients. Thank you, Lars.
Yeah, thank you, Gigi. So as we're moving to patients with longer life expectancy, we have seen there's also been a shift to try to optimize the procedure to try to refine it in order to have treat patients with longer life expectancy. One of the Achilles heel for TAVI has been the conduction abnormality. And in the beginning, we were saying that having a new permanent pacemaker after a TAVI procedure was a benign complication. But I think we have now robust data showing that it's going to impact the prognosis of the patient. The patient will have higher mortality and also more heart failure hospitalization. And we all know what the issue is, that there's a close proximity between the aortic annulus and the conduction system. So the lower we implant the valve, the higher will the risk be for having conduction abnormality. Most of us starting out having the C-arm projection in a kind of LAO cranial projection, maybe a classical tree-cusp overlap view, and that will give us the tree-cusp aligned with the imaging plane, of course, but we're also going to introduce a parallax to the delivery system. And particularly if you use self-expanding technology, most of us will move the C-arm in order to take the parallax out of the delivery system. But then, of course, we're going to tilt the aortic annulus plane. So we still not have an optimal implantation view. And it can also be illustrated here. You see the tree-cusp coplanar view in an LAO projection. If you take it out, going down to the lower S-curve, we have no parallax, but you have quite a large distance between these 2 curves. So of course, the ideal scenario will be to have this C-arm projection where these 2 S-curves are crossing, the double S-curve crossing point. Most of us cannot find that in daily routine, but it's now been suggested to have this cusp overlap technique. And you can see on this, the cusp overlap position is quite close to the double S-curve crossing point. And also you have a very small distance between these 2 S-curves at this position. And of course, this is going to give us a better understanding. We're going to have the 3 aorta cusp almost aligned with the imaging plane and have almost no parallax in your delivery system. So this is what most of us is doing nowadays. We have moved from this tree-cusp coplanar view in an LAO cranial projection towards a cusp overlap position in an RAO caudal projection in order to have getting as close as possible to the double S-curve crossing. And also working in an RAO caudal projection is going to elongate the left ventricular alpha tract and thereby altogether have a better understanding how deep are we with this implant during the procedure, and thereby having a more predictable high implantation of the device. Does it work? I mean, we have seen several reports. This is our Copenhagen experience. We had a quite abrupt change from this LAO projection towards this RAO caudal projection. Identify the patient treated before we shifted, and afterwards we did a matching from age, gender, STS score, pre-procedural right bundle branch block, LVOT calcification, and bicuspid aortic valve, having 183 patients in each group. And what we found was what has been reported in several institutions, a 50% reduction in the need for permanent pacemaker, coming down from 15% to 8%. So certainly moving to this cusp overlap technique is going to reduce your need for permanent pacemaker, which is going to be important as we move to patients with longer life expectancy, because it's going to reduce mortality and risk for hospitalization due to heart failure. Another issue after TAVI is access to the coronary arteries. And you can divide all TAVI platform into 3 groups: those with a low stent frame with intra-leaflet position, and those with a high stent frame with either an intra or supra-leaflet position. And particularly when you have a supra-leaflet position, it may be difficult to access the coronary arteries after valve implantation. And this was nicely demonstrated in the re-access study, very simple study, 300 patients undergoing TAVI. The physicians was asked to cannulate the right and left coronary arteries before valve implantation and immediately after. And as you can see, in 23 patients, 7.7% of the patient, it was impossible to access both coronary arteries after valve implantation. And actually, 22 out of those 23 patients was treated with the Evolut platform. So for that platform, it was almost 20% of the patient where it was not possible to access the coronary arteries. And again, moving to patients with longer life expectancy, this is not going to be acceptable. The main reason that you can do it is that when you implant this valve, it's going to be rotated randomly in the aortic annulus. And then you end up in a situation here as on the left-hand side where you have what we call severe commissural misalignment. We have the leaflet post right in front of the coronary arteries. It's going to be difficult, or as you just saw, in some cases even impossible to access the coronaries. So what we should do is to aim for commissural alignment. The same thing as a surgeon will do, having the commissures of the transcatheter heart valve aligned with the commissures of the native valve. It has been suggested by Gilbert Tang to introduce the delivery system with the flush port 3 o'clock instead of 12 o'clock as initially suggested by Medtronic, in order to have near commissural alignment in most patients. And Gilbert's own data actually showed that it had an impact. It reduced the rate of severe commissural misalignment from 40 to 20%, so a 50% reduction in the risk of severe commissural misalignment. But again, it's still 20%, the same number as we saw in the re-access study. So we need to do it better. We need to get for what we call patient-specific commissural alignment. And actually going back to this cusp overlap view where we overlap the right and the left coronary cusp, that C-arm projection is actually ideal to aim for patient-specific commissural alignment. Because if we in this projection know where the leaflet posts are positioned on the stent frame, we just need to make sure that one of the stent posts are positioned on the right-hand side of your fluoroscreen. So as you can see here on the right-hand side, right and left cusp is overlapping. The commissure between those two cusps are pointing to the right of the fluoroscreen. So if you have one of the leaflet posts at that position, you're going to have patient-specific commissural alignment. For the Evolut platform, you can aim for that C paddle. There's 2 paddles used to attach the valve to the delivery system. The C paddle is positioned over one of the leaflet posts. And also you can look at the inflow portion of the delivery system. You need to see this hat mark configuration. If you see that C paddle on the right-hand side of the fluoroscreen and the hat mark configuration, you know you're going to have patient-specific commissural alignment. It also showed here in a different way. The eye is a C-arm, right and left cusp is overlapping. Commissures is pointing to the right of the screen, position one of the leaflet posts on the right. So this is a fluoroscopy you see here, starting with the introduction of the delivery system with the flush port 3 o'clock, going around the aortic arch, go to a cusp overlap view, see that you have the C paddle on the right-hand side of the screen, and also you have this hat mark configuration. And after release, you can have the confirmation, C paddle on the right-hand side, non-C paddle on the left-hand side. This patient got patient-specific commissural alignment. One of the problems is that not all patients have the coronary arteries taking off in the middle of the cusp. Some of them, particularly for the right, you have what we call coronary ostial eccentricity. So the right coronary will not take off in the middle of the cusp, but approaching the non-coronary cusp. And we actually look into that, 200 patients with tricuspid aortic valve and 200 patients with bicuspid aortic valve. For tricuspid aortic valve, it's around 3% of the patients who have moderate to severe coronary ostial eccentricity. If you go to bicuspid valve, it's close to 7%. So of course, for these patients, you need a different approach. And for these patients, instead of going for this cusp overlap view, you could decide to have your C-arm so you have a coronary ostium overlap view. So for each individual patient, start to look at your CT scan, where are the coronaries taking off, and then make a decision, do you need to have valve implantation using the cusp overlap view, or should you choose coronary ostium overlap view in order to have patient-specific alignment and thereby easier access to the coronaries in the future. Thank you.
So thank you very much, Lars, for this extremely comprehensive review of contemporary techniques to achieve the best outcomes, procedural outcomes for our patients with the cusp overlap technique and using the commissural alignment and in the future coronary alignment. So maybe a question for you, Lars. We've seen that with the cusp overlap technique, now we can achieve with a self-expanding platform a single-digit pacemaker rate. And that was the Achilles heel of that device in the past. We are not talking anymore about regurgitation, but because all the contemporary devices achieve none to mild regurgitation in the vast majority of the patients, but pacemaker was one of the issues. With that single-digit pacemaker rate, do you think that we can foresee or anticipate next day discharge for patients treated with a Evolut Pro Plus platform?
Yeah, I think at least in our institution, most of our patients will go home the next day. Of course, there will be some patient who is very prone to get conduction abnormality and need for permanent pacemaker. Patient with very short membranous septum, patient with pre-existing right bundle branch block. And we know that some of these patients, even when you pass the valve with a guide wire, they will have complete AV block. So I don't think it's ever going to be zero, but it's certainly going to be at a much lower rate than we saw just a few years ago.
So thank you very much, Lars. Ran, I have one question for you. So if we combine your learnings, the learnings from your talk and the ones from Lars, we've seen that mainly in the contemporary practice, it's direct AV, no predilatation, cusp overlapped projection, and coronary commissural alignment. What about predilatation? What are, according to your experience, the remaining indications for predilatations when we use a self-expanding platform?
I think that in our practice is quite uncommon to have predilatation for many years already. But I think that there are some circumstances in which we would consider predilatation and actually perform predilatation. If the calcification is truly overwhelming, we might consider it, especially if the gradients are truly excessive. So in combination of very high gradient with calcium score that is, several thousands, we may consider it. And in bicuspid scenario, I think that in some of the bicuspid with calcified RAF, we would like to have annular preparation or even leaflet preparation. But I must say that we don't have a systematic approach towards predilatation. It's only in those extreme circumstances that I've mentioned. Most of the patients would not have predilatation.
So very clear. So thank you, guys. I think it's now time to dive more into details about the techniques per se. So Doug, would you drive us through some cases about contemporary techniques to optimize the outcomes for our patients? So the floor is yours, Doug.
So thanks very much, Didier. I don't know if you've got my slide set. Okay, my slides are just coming on now. So thanks very much, Didier. I'm going to be presenting a case, and I'm going to be taking you through what we do, which is obviously quite subjective, but then taking you through why we do what we do. Okay, so I'm going to be presenting a case of a 34 Evolut Pro Plus valve. Now, of course, we know that the Pro Plus is a significant advance with reduction in French sizes for the smaller size valves and the addition of the wrap to the 34 in comparison to the Pro. So I'm going to present a case of a chap we formed recently, 74-year-old man. He had severe emphysema and low flow, low gradient severe aortic stenosis with a very high calcium score of nearly 5,000. So this is his CT. You can see that he's clearly in the range for a 34 valve. And you can also see a lot of calcium under the left coronary at annular level coming into the lumen, and in LVOT level, marked calcium in the lumen, as well as a very calcified valve. So these are the setup shots. We always do setup shots in 3 cusp and cusp overlap. It's useful to take that 3 cusp view because then you can match that with your CT angles to make sure that any correction is applied to your CT angles. And it's important to make sure that the cusp overlap view is a true cusp overlap view for the reasons that Lars mentioned. If you're off the cusp overlap view, then you won't get, or if you're off an annular plane view, such as the cusp overlap view, you won't get accurate depth information from the aortogram. So in this case, as Ran mentioned, very calcified valve, we would predilate. In fact, we use quite liberal predilatation in Manchester. And you can see here we're using a Lundequist, double curve Lundequist wire. Okay, so this is a good position for the double curve Lundequist. There is a learning curve to using this wire, and it wants to be in between the mid-ventricle and the apex. Okay, so you can see how this wire aids stability. There's really no motion at all of the device, and that's because the wire is pushing this device deep into the right non-commissure. And that's one of the most attractive features we feel of this wire. So then we rapid pace again to reduce any motion of the device having gone up to the 3rd or 4th node. Okay, so we're then checking the device in our cusp overlap view, and in fact we don't correct parallax in this view. I think that can give misleading information. What we're looking for here is to make sure the prosthesis is below the non-coronary cusp in this view. Now you may be able to see that it's below the left as well. We don't tend to worry about the right because it should always be below the right. But then we flip over to an LAO view and confirm that the device is below the left cusp in that view, but also importantly, make sure there's a nice central location to the delivery system. And then relieve any tension on the wire and do a very slow release. So pull the wire back well back and a very slow release. Okay, so achieving this, we've achieved a nice depth. We've got no aortic regurgitation despite a lot of calcium. We've done a pre-dilatation. We haven't had to post-dilate. And as Lars showed, we've got nice commissural alignment. Again, I'll show how we confirmed that in this case. Okay, so I've mentioned about the baseline shots. It's important to get them as accurate as possible. We predilate perhaps 50% or perhaps more of our valves. It reduces post-dilatation and any worries about that, particularly if the valve's quite high. But also we feel it aids wire seating and helps the wire get deep into that commissure to aid stability of the valve. And of course, particularly when there's heavy calcium or there's a lot of calcium at LVOT or annular level, where you want to minimize post-dilatation. Okay, so we also use a double curve Lunderquist wire in most of our cases. There is a learning curve to this wire, but it does aid to that stability. So I'll just show a case here. This is with an Inui wire, and you can see that the wire there with the small tip, the double curve Lunderquist got a very large tip. You can see here the wire with a small tip is not stabilizing the device. There's really a lot of motion there, and that's going to make choosing your depth much more difficult. So as Lars mentioned, the cusp overlap view is an ideal view to confirm commissural alignment. In the bottom left image there, you can see that the hat marker in this case was facing towards us, and that's exactly what we want. We've achieved that by using the 3 o'clock position, and the final result shows nice commissural alignment. Okay, so in terms of judging depth, we take obviously pigtail shots, and generally we want to align the bottom of the frame with the bottom of a well-seated pigtail in the non-coronary cusp in the cusp overlap view. But in different anatomies, such as horizontal aorta, that will be different. In this example, the device would have to be significantly above the pigtail. As I say, we use rapid pacing. There is some evidence that aids stability of the device and helps achieve more accurate depth. And then we check the position at 80%, looking in the cusp overlap view to see that we've got some prongs below the non-coronary cusp. And then over in the LAO view, we see whether the prongs are below the left coronary cusp. So that's how we judge whether we've got the valve below the annular level. We don't correct parallax, because if you correct parallax, that can make the valve look higher than it actually is. And we try and get the delivery catheter in a nice central position when we're releasing without too much push or pull on the device, again to minimize movement. And finally, as I say, retract the wire, again to minimize that movement on release. And as we've discussed, the additional wrap with the Evolut valve helps very significantly, and we has practically eliminated significant aortic regurgitation. That and a good accurate placement maximizes the radial force of the Evolut device. So that's what we do in Manchester, and those are our reasons. So thanks very much, Didier. Back to you.
Thank you very much, Doug. That was a very comprehensive step-by-step description with all these tips and tricks about the contemporary cusp overlap technique, and we could clearly see how easy and reproducible it can be just in achieving no regurgitation, high implant with potentially a very low pacemaker rate for your patient and a nice commissural alignment. There is one question coming from the audience, our friends connected online, and maybe Doug, you could try to address that. It's about the heart marker. How can you be sure that the heart marker is located center front and not center back based on the projection that we have on the cusp overlap? If I want to make it clearer, do you use another projection just to see if you are center front or center back? Just for the audience, thank you.
Okay, I think, well, we don't basically. We don't tend to adjust the position more than put it in at 3 o'clock. We put it in at 3 o'clock and we don't further adjust the position. I'd be very interested to hear from Lars as to the success of adjusting the position, but we just start at 3 o'clock, and if the hat marker is facing us in the cusp overlap view, then we're happy and we know we're going to get good commissural alignment. I think for it to be 180 degrees out of phase, I think that's not going to happen. But it may be that the hat marker is not looking perfect in the cusp overlap view. And then there's a question about whether you try and adjust it and whether you go back to the descending aorta to try and adjust it, or whether you try and adjust it in place. I've got to say, Didier, that we don't have a lot of experience with adjusting it. I would say that what we found is that looking at the hat marker on the side as you're going round, which is another way of looking at it from the descending aorta, that does give you an indication, but we don't find it's particularly reliable. So from our experience, you get what you get, and it's best assessed in the cusp overlap view.
So exactly, so I found it quite useful exactly when you track, making sure that the heart marker is located on the outer curvature of the aorta in the LAO projection, and you will get the appropriate appearance in the areocaudal cusp overlap. Question for you, Lars. What about fine-tuning the rotation of the catheter? Any tips and tricks that you could share with us? How do you do that? Is it feasible first?
Yeah, just back to your questions before about how do you ensure that it's actually in the front, this head marker, and not in the back. So if you change from this cusp overlap technique going back to an LAO cranial projection, you need to see it on the outer curve on the left-hand side of the screen, the big marker. If it's on the right-hand side, it's opposite. But again, if you start to introduce it with the flush port 3 o'clock, it's often going to be close to commissural alignment. So what we do is we're passing the aortic arch in an LAO projection. When we in ascending aorta just above the aortic annulus, we go to the cusp overlap technique. We check for this marker with the head marker and the C paddle. If you see that we need to do an adjustment, we do that. Often you have to talk about 180 degrees on your delivery system before it starts to talk. And when it's talking and you're happy about it, just release it. You pass the valve and you do your deployment. It's feasible for most of the cases, but some of the cases, if you have tortuous anatomy, there will be cases with the Evolut platform where you're not able to do it. But again, I think maybe the most important thing is not always to get perfect commissural alignment, but it is to avoid severe commissural misalignment.
Thank you very much. So I have to say, guys, that this was a fantastic webinar from my point of view, because thanks to you, we understood how important is the choice of the first valve, just to make sure that we achieve the hemodynamic goals and we make sure that the durability of the device is going to be as long as possible, particularly when it comes to low-risk patients. We have reviewed the contemporary techniques with the cusp overlap and the commissural alignment and shared all these tips and tricks that are going to make our life easier, just to make sure that we fulfill the goals that are necessary for our patients, particularly, once again, for our low-risk patients. So it was a real privilege for me to share this webinar with the three of you guys, and I guess that all our objectives were met. I would like to thank Medtronic for supporting this webinar with unrestricted educational grant. So it's time to end this webinar, and I wish you all the best for the rest of TIO 2022. And once again, thank you guys for sharing your experience with us.
Thank you very much.
Thanks, Didier. Thanks very much.